think I'll go ahead and get started. For those who don't know me, I'm Adrian Abreo. I'm one of the newer faculty in the Division of Nephrology. And I'm glad to be able to spend this time with you talking about an area of research interest for me, but I think also of important clinical interest, not just to nephrologists, but to all medicine doctors alike, because we all deal with volume overload, and we all know, even in patients with heart failure, that sometimes our estimation of volume overload may not necessarily be accurate. And some of the research that I've done in the past and what I'm going to discuss today is looking at hemodialysis patients, but ways that we can actually kind of come up with a more quantitative way to measure volume status. So I don't have any financial disclosures. So this is an outline of the talk. I'm going to start by talking about volume status in hemodialysis and how it's approached currently. Next, I'm going to discuss the concept of dry weight, or what we use as a target weight in the dialysis unit, and how we come up with that. And then I'm going to talk about strategies for trying to improve our dry weight in patients on hemodialysis by probing dry weight, a method called relative plasma monitoring, using chest ultrasound, and then finally the area of research that I've spent most time with, bioimpedance spectroscopy. So to think of a dialysis patient and their volume status, it's often best to think of a wave. And that is that the patient comes in with a certain amount of volume on. They're typically volume overloaded. We set, as nephrologists, we set what's called the ultrafiltration volume. So we determine through our order and what we program into the machine exactly how much fluid we take off. And oftentimes, though we put in a number, we don't exactly know exactly how many liters of fluid the patient has. So this patient comes in volume overloaded. We take off a certain amount to what we think is their dry weight, which is their normal weight if they were not on dialysis requiring this. Then they go home, they gain the weight again, we come back and we take it off. So this is a nice schematic to try to kind of describe what I'm telling you. So the patient comes in volume overloaded. We prescribe this amount of fluid removal, and the patient leaves with this weight. They leave on Monday, they come back on Wednesday, and now they're here. And we kind of do this. And we get caught up in this, what's called the interdialytic weight gain, the gain that the patient is, the weight that the patient is gaining in between the dialysis treatment, which is this. And oftentimes we have an estimated dry weight that we've set as this, and we say the patient has gained 4 kilograms, we're going to take off 4 kilograms. The challenge with that is that we don't know how accurate this is, and I'll go over how we kind of have estimated this up until this point and how we can make it better. Because this may actually be the patient's true dry weight. And there are consequences to leaving dialysis with extra fluid on. And most importantly, as you'll see through some of the previous studies, it's hypertension. There's quality of life and functional status consequences to not achieving a true dry weight. So why do patients gain, when we focus on interdialytic weight gain, or why patients are gaining weight in between dialysis therapy, there are a couple of reasons that may happen. One, probably the most common, is a salty diet. So we ask the patients to restrict their sodium intake. To a lesser degree, it can be related to the dialysate sodium that we're prescribing. A lot of our patients are diabetics, and if they're uncontrolled diabetics, high glucose levels can contribute to thirst. High angiotensin II levels. Angiotensin II is a potent dipsogen that can cause the patient to want to drink more. And then also psychological factors that may cause the patient to drink more fluid. These are things that we're tackling, but this really relates more to the interdialytic weight gain than the true absolute dry weight. Of course, this will affect how much fluid we can take off on dialysis, and the patient may not be able to get to their dry weight if they have too much weight gain in between dialysis. So traditionally, even in practice today, what we're using to kind of assert or determine dry weight is clinical exam. And I'll tell you, clinical exam, though some veteran nephrologists may feel like they have it down is actually pretty poor when you look at objective measures on how much fluid somebody actually has on them compared to what somebody would say their exam is. So there's two newer methods that I mentioned earlier, bioimpedance spectroscopy and relative plasma volume monitoring, that can help guide us in determining what the true dry weight is of the patient. These are not diffusely used at this point. In fact, bioimpedance in the United States is still only experimental. Some units use relative plasma volume monitoring. The San Francisco VA hospital actually uses it, and it can be an important clinical tool, and I'll go into more details on that. So what is dry weight? I keep making mention of this dry weight, and how has it been defined over the years? So in 1967, it was defined as reduction of the blood pressure to hypotensive levels during ultrafiltration. Again, ultrafiltration is the volume of fluid that we're pulling on dialysis. In 1980, it was defined as the weight obtained at the conclusion of regular dialysis, below which the patient would go into shock. In 96, the weight at which the patient can remain normotensive until the next dialysis session. In 2008, there was a push to use more objective measurements with calf bioimpedance. And then in 2009, the definition was kind of modified to the lowest tolerated post-dialysis weight via gradual change in post-dialysis weight with minimal signs and symptoms of hypo or hypovolemia. So basically, what the patient can tolerate with very small changes to their estimated dry weight. So I think we have an over-reliance on using edema. Edema is certainly a sign of volume overload at times, but when they've looked at hemodialysis patients, there's an objective measure such as IVC ultrasound or relative plasma volume monitoring. They haven't always found a correlation between lower extremity edema and these kind of objective markers of volume overload. We have to be cautious in overinterpretation of our clinical exam. So there's a human element that also stands in the way from a nephrology standpoint of a patient achieving their dry weight. You saw through all those definitions, a lot of them involved the patient becoming hypotensive, going into shock, trying just keep pulling fluid until the patient doesn't feel well. So there's a human element where basically the patient is in dialysis, we've prescribed a certain amount of fluid removal, and the patient becomes hypotensive, and they complain of dizziness and cramps, and they feel nauseated. So what do we do next? What's the kind of human response to this? It's stop pulling fluid, increase their dry weight, and give them fluid back. And sometimes that response actually stands in the way from a patient getting to their true dry weight. You'll see in the next study that I'm going to talk about, the DRIP study, how they kind of move around that. But this is certainly a challenge in the dialysis unit, that when somebody's hypotensive and not feeling well, our first inclination is to give fluid, stop the ultrafiltration, and go up on their dry weight. When in fact, we may just need to modify their dry weight slightly, not make a big change. And I think in practice, a lot of times, this is an inhibitor to actually achieving a true dry weight. So the first strategy that I'm going to talk about is probing dry weight. And this is simply small incremental changes in the dry weight with each treatment. And this was really elucidated in a trial called the DRIP trial. And the objective of this was to determine whether additional volume reduction would improve blood pressure in hypertensive patients on hemodialysis. And there were two groups. One group was just assigned to normal care, where a physician would see them and they would prescribe the dry weight as they saw fit. And the other group had a very strict regimen for how fluid would be removed in these patients. So in the intervention group, the ultrafiltration group, they were initially prescribed an additional fluid removal of 0.1 kilograms per 10 kilograms of body weight. And that was carried out unless they couldn't tolerate it. But compared to what we would normally do, which was stop the fluid removal and increase their dry weight, they actually just reduced that goal by 50%. And if the patient had symptoms, muscle cramps, or hypotension, the goal was reduced. It was not increased. It was simply reduced until they could not even tolerate a 0.2 kilogram incremental weight loss. And after they did that, they kind of looked at blood pressure and weight loss. And ambulatory blood pressure monitoring was tested after the midweek hemodialysis session. And during the trial, there were no changes in antihypertensives allowed at all. And this was the result. And this is important because this really shows how tied volume status is in a dialysis patient to blood pressure. So after about 4 weeks, you can see the systolic blood pressure drop by about 7.4 millimeters of mercury, and the diastolic about 3.6. And those were maintained through the 2-month trial. And on average, patients' dry weight was reduced by 1 kilogram. So, and that's from what people thought was their dry weight before. So it shows that oftentimes our patients have more volume that can be removed to try to optimize things like quality of life and blood pressure as well. It's just a matter of being very standardized in how you remove it. Because this control group is just standard physician care. Physicians deciding how much to take off the patient versus a very protocolized method of removing fluid. So the next strategy that I'm going to discuss is relative plasma monitoring. And this is also known as the crit line monitoring. And basically this uses photo-optical technology to basically monitor absolute hematocrit throughout the dialysis treatment. So you're looking at changes in the plasma volume throughout the treatment. So this is an example that I found in the literature which really shows kind of how crit line works. So this is a patient, he was 42 years old, and he was a hemodialysis patient. His blood pressure was 150/90 on 4 antihypertensive medications. And this is the crit line of his dialysis treatment. So you can see he had a 4-hour treatment, and his line is completely flat. And a flat line basically indicates that the patient typically is volume overloaded and has more volume to give. So this patient was actually enrolled in the DRIP trial that I just mentioned. And he was randomized to the ultrafiltration group where his dry weight was probed, and he had continuous fluid removal until he was not able to tolerate 0.2 change. And they did the treatment, and after 2 months of treatment, this is what his crit line looked like afterwards. So you can see it's a big difference. Now he has a nice slope, which is indicative of closer to euvolemia in this patient. And this can be helpful because if the crit line is very flat, it suggests that the patient has more fluid to give and that you should attempt to take more fluid off. So this is the relative plasma volume percentage. So it's just basically, it's looking at the absolute hematocrit, just like if somebody is hemoconcentrated when they're volume depleted. It's the same sort of concept, but you're monitoring it in real time to try to get an idea. If that number isn't changing too much, then the patient may be volume overloaded. And again, this works in patients who, I mean, this is a very subtle thing. These aren't patients who have pulmonary edema and 3+ edema and bibasilar crackles. These are patients that may appear euvolemic. But again, the subtlety, and that's why I think objective measurement of volume status is going to be an important kind of next step in the care of nephrology patients who are on dialysis. So they looked back at the DRIP trial study, and actually they had crit line monitoring at that time. And they looked at baseline and 8 weeks in 100 patients who had their dry weight probed and 50 who served as controls. And they found that probing of dry weight leads to steeper slopes, as we saw in that one patient, Those with flatter slopes at baseline were able to have greater weight loss. So if you're doing crit line, you see a flat line, then that indicates that you may have more fluid to give. The baseline slope and also the intensity of weight loss were important to determine subsequent changes in the slope. And the RVP slopes actually predicted subsequent reduction in blood pressure. Because, again, if there's one thing you get from this discussion, it's that in a dialysis patient, volume status is tightly linked to blood pressure. So things were looking good with crit line monitoring, and then they decided to do a randomized trial. So this was published in JASN. And patients were randomized to crit line versus conventional clinical monitoring without any sort of guidance for ultrafiltration. There were 227 patients randomized to the crit line arm and 216 randomized to the conventional arm. And in the control group, there were no algorithms. It was treat your patient as you see fit. The crit line group had this algorithm to follow. And one of the challenges, or one of the criticisms of this study was that you can see if the slope is flat, it says increase the ultrafiltration goal. They don't really give any guidance to how much you should increase. Unlike the drip trial where there were very strict objective parameters for how much to remove in terms of fluid, this just kind of says if it's flat, increase your goal. If the slope is steep, then you may want to back off on your goal and basically monitor for symptoms. This was the patient characteristics. The two groups were pretty evenly paired in terms of patient characteristics without any statistically significant differences. And these are the results that kind of came as a surprise. Actually, the crit line group had a higher, had actually more hospitalizations that were related to all types: access, cardiovascular, non-access related. These patients who had the crit line intervention were actually admitted more. And actually at 6 months, mortality was greater in the crit line group than the conventional monitoring group. And this kind of baffled a lot of people because they were a little confused as to why this may be the case. When you go back and dig deep into the paper, there are a couple of possible explanations. One, for some reason, the control group in this study, their mortality was much better than actually published historical data. And it may be related to something called the Hawthorne effect, where when somebody is being observed and monitored, behavior from the physicians or the patients may be different. And that could be one reason, because if you compare to the historical known mortality for normal dialysis patients, there's actually no difference in mortality between no statistically significant difference between crit line monitoring and these historical controls. But in this group, there was, it looks worse for crit line. The other thing was that I made mention of is that there was not a very standardized protocol. It just kind of left it up to whoever was performing the dialysis treatment as to how much they wanted to increase the ultrafiltration. So they may have been overzealous kind of in their goals for ultrafiltration. But regardless, this is the study that we have that showed that there were some issues with crit line. It is still used in certain dialysis units around the country. The next modality is chest ultrasound. So using chest ultrasound, you can get what's called a comet tail artifact due to acoustic impedance in patients with lung congestion. And so on the left, you can see what the normal ultrasound looks like. On the right, you can see these lung comets. And these are associated with basically lung congestion in patients on hemodialysis. And they've looked at this, and patients with severe lung congestion measured by chest ultrasound were at a higher risk of death compared to those with no congestion. So this study looked at chest ultrasound performance in 75% of patients. And one important thing that came out of this study is that 63% of patients, when they walked into the dialysis unit, exhibited moderate to severe lung congestion. And that just kind of shows you how volume overloaded patients can get. And unfortunately, if it was an ideal world, patients would get dialysis every single day to prevent these sorts of fluctuations in the wave that I showed you on the first line. Unfortunately, there's financial and kind of practical barriers to that. But physiologically, we would ideally like to take some fluid off of a patient every day. And lung fluid excess was strongly associated with New York Heart Association class, ejection fraction, left atrial volume, and pulmonary pressure. Lung volume did reduce after dialysis, but still 31% of the patients had pulmonary congestion of moderate to severe degree after dialysis, which is kind of goes with the other studies that we're showing, that we've seen that there may be more fluid to give despite our estimation of dry weight. And even after dialysis, lung water, as they call it, maintained a strong association with ejection fraction, atrial volume, and pulmonary pressure. So the last kind of strategy that I'm going to spend a little bit more time on is bioimpedance spectroscopy. So the body in its simplest form can be broken down into fat mass and fat-free mass. And using this knowledge, basically what bioimpedance does is using a small electrical current that's sent through the body to try to estimate how much fluid is in the extracellular space and in the total body water. So bioimpedance measures tissue conductivity in response to a small bioelectrical current. And this current is conducted well by water and electrolyte-rich tissues like the blood and muscle. But it's conducted very poorly by fat, bone, and air-filled spaces. So to perform this, you actually put what looks like an EKG lead, and you place it in a tetrapolar arrangement on the hands and the wrists, and then the foot and the ankle. So when I did my my studies, this is the machine that we used. This is a bioimpedance machine. So basically the patient is hooked up. The measurement takes about 1 minute, which is very convenient and would be very useful in a dialysis unit. Because all dialysis patients, when they come in for treatment, they get weighed anyway. And this would be a perfect adjunct to do while the patient is being weighed to get a little bit more information. So bioelectrical current can be applied over a range of frequencies or a single frequency. At low frequencies, you're not getting much conduction, and that allows you to estimate the extracellular fluid space. At high frequencies, you're getting more conduction, and that allows you to estimate total body water. So this is a patient, a dialysis patient, who is having the procedure performed. I mean, she basically has the electrodes on her wrist and hand, and then on her foot. There's the machine that I showed you. It takes about 1 minute, and it actually gives you, it outputs an ECV volume and a total body water volume. So it's very easy to do, and it gives you very hard numbers to use. You can use segmental versus whole body bioimpedance. Segmental is just using a certain part of your body, such as the arms, trunk, leg, or calf. Calf bioimpedance is the most validated, one of the segmental ones. Or you can use whole body, where basically it was the setup that I showed you before. You can do single frequency bioimpedance versus multi-frequency. Single frequency is just one current at one frequency, and that will only give you a total body water. It won't give you any information on the extracellular fluid. And from this, you can calculate the fat-free mass, or you can use a multi-frequency bioimpedance, and we call that bioimpedance spectroscopy. And that goes from a range from 5 to 1,000 kilohertz, and that will give you information on the intracellular water, extracellular water, and the total body water. So as I mentioned, BIS compared to BIA, BIS is the multi-frequency one, and you get information on all of these fluid compartments. So you can imagine if we're trying to deal with volume status in a dialysis patient that's hard to tell, having some sort of quantitative measure of extracellular fluid could be advantageous to us. So just kind of looking over the benefits of each of these strategies of estimating volume status, you can see that they all are pretty sensitive to volume status, and they're all fairly reproducible. But what the advantage of bioimpedance is that it gives you a number, and that you can do it also beforehand. Chest ultrasound you can do beforehand, but you still don't know what that means in terms of fluid. You can know that the patient is volume overloaded in a qualitative sense. Same for relative plasma volume monitoring. You have to already be performing dialysis to get information. You can't do it before. But the real advantage of BIS is that you can do the measurement beforehand, get some information about how much fluid to take off, and actually try that. So some of the studies of bioimpedance, this one study looked at 208 prevalent dialysis patients, and they found that when the patients were volume overloaded, defined by a greater than 15% expansion of the extracellular fluid space, that was a predictor of all-cause mortality with a fairly high hazard ratio of 3.41. And then using BIS, reductions to levels of less than 15% extracellular volume led to reductions in blood pressure without an increase in intradialytic symptoms. So it's just another way to grossly get a picture of volume overload. But can we use this in a more kind of titrated way to actually determine how much fluid to take off? This was a regimen that was described and published in CJASN. And the aim was to see if you could use bioimpedance spectroscopy to actively manage fluid in a dialysis unit, and whether you would see any benefit using this. So they were really looking at the feasibility of using this technology. And again, this is not approved for clinical use in the US just yet. So pre-dialysis fluid overload was measured by BIS. And they used this formula where they estimated fluid overload using BIS before, and then they accounted for how much fluid was taken off to come up with the post values. And they came up with this figure for the week, which is the average, the time average fluid overload, or the TAFO. And using this metric, the people in the unit would decide whether to take more fluid off or not. So this was the protocol. When the time average fluid overload was greater than 2.8, the patients were to have their post weight reduced by 1 kilogram per week. If it was between 1.25 and 2.8, you had a smaller reduction. If you were between minus 0.25 and 1.2, you did nothing. You just kept them at their current dry weight. And if it was less than 0.25, then you actually increased the post weight. So they did account for volume depletion in these patients, because our patients can become volume depleted as well. And the results were impressive. I mean, time average fluid overload decreased by about 1 liter. And that was actually just in a couple of weeks, I believe, in the fluid overloaded group. And in the group that was actually volume depleted, their dry weight was raised by 0.59. Which is showing you that you can actually use this to actually titrate in an outpatient dialysis unit a patient's dry weight. And every 1 liter change in fluid overload was accompanied by almost a 10 millimeter of mercury per liter change in pre-dialysis systolic blood pressure. So that's an important point. You can see here, it's almost a linear relationship between the fluid overload and the change in blood pressure. And that's why in a hemodialysis patient, an important teaching and learning point is that when a patient is hypertensive, the first thing you want to do is try to challenge their dry weight for exactly this purpose. You don't want to add the 6th antihypertensive medication without being sure that the patient is at their dry weight. And all these studies just kind of reinforce that fact. So this study showed that it was possible to improve fluid status in volume overloaded and volume depleted patients using a strategy that employs BIS. That the improvements in fluid overload were linked to blood pressure changes, and that the blood pressure changes were highly correlated to volume status in dialysis patients. Okay, so that's kind of the background. Now I'm going to transition into some of the work that I've done, where we actually use BIS to answer a couple of questions. So the cohort that I use is called the active adipose cohort. It's a cohort study that was a subsection of it was a special study of the USRDS. And we had 778 patients from San Francisco and Atlanta who were on hemodialysis that were prevalent patients that had been on hemodialysis. And we used blood pressure and pre-dialysis bioimpedance spectroscopy measurements to answer a couple of questions. So historically, through observational studies, patients with post-dialysis blood pressures less than 110, systolic blood pressures, have been found to have higher cardiovascular and all-cause mortality. And there's a lot of debate as to why this could be, that it may be patients who are sicker, who can't really tolerate ultrafiltration. But our goal was to see if there was any association between BIS estimates of fluid excess and post-dialysis systolic blood pressure in this cohort of patients. So basically, what we're trying to do is we would take a measurement, BIS measurement before, we would estimate how much fluid that patient had to give in essence, using our formula. We would see how much the patient actually had removed, and we wanted to see if that difference, if they had more removed than what we thought they had to give, were those patients more likely to be hypotensive at the end of dialysis? So this was the study that was published, and we were looking at exactly that. And this was the formula that we used. It was actually French scientists that had come up with this formula to try to estimate volume overload using ECW and ICW. So we used this formula to determine volume overload before dialysis, also known as how much fluid they had to give, which was this fluid overload pre. Then we knew the amount of ultrafiltration that the patients had during that treatment. And then we would determine the fluid overload after dialysis. And our hypothesis was that if the patients actually had more fluid taken off than they had to give, that they would be more likely to be hypotensive. So this was the characteristics based on quartile of post-dialysis fluid overload. And there were some differences in age, but we adjusted for all these variables. ESRD vintage is how long the patients have been on dialysis. And there were differences in volume, which is expected because we were dividing the quartiles by fluid overload. And this was the result. So when we did multivariable adjustment, the post-dialysis fluid, every liter of post-dialysis fluid came with a 0.86 odds ratio of being hypotensive after dialysis. So essentially, the less fluid overloaded, or the more fluid overloaded you were at the end of dialysis, the less likely you were to be hypotensive, which seems logical, but basically nobody had ever looked at if a single measurement before dialysis could be useful in trying to prevent hypotension. And this is a graph looking at the log odds of the post-dialysis systolic blood pressure, less than 110, and post-dialysis fluid overload. So essentially, once you started taking off more fluid based on the bioimpedance readings, you were much more likely to become hypotensive after dialysis. So basically, we suggest that this should be looked at in a prospective manner. Basically, we should go forward and look to see, now that we know that there is a correlation that if you do excess ultrafiltration beyond what we would deem necessary by BIS, that you're putting the patient at risk for hypotension. So really to validate this further studies need to be looked at prospectively to see if we can minimize these episodes of post-dialysis hypotension without leading to volume overload. So the next study was looking at patient-reported sleep duration and quality in patients on dialysis. And I kind of made mention of the fact that patients who are chronically volume overloaded patients in general on ESRD have very poor quality of life through objective measures, and they have a high incidence of frailty and really poor physical function altogether. So patients on dialysis have been noted to have very poor sleep, and there's a high prevalence of sleep disturbances, up to 69% in some studies. There's some hypotheses as to why this may be the case. One is that as patients lay back, or they're recumbent with excess fluid, they get rostral fluid shifts, and that can actually exacerbate the severity of obstructive sleep apnea in patients on dialysis. Some suggestion of this came from one study looking at peritoneal dialysis patients, where patients were converted from doing peritoneal dialysis exchanges during the day to nocturnal peritoneal dialysis, where fluid was being removed at night. And they found that the apnea episodes were much higher when patients were doing daytime exchanges as opposed to nighttime exchanges. At nighttime, when the fluid was being removed, they had fewer apneic episodes, which kind of supports this theory. But previous studies have not exclusively focused on how volume is related to quantity or quality of sleep. So our goal was to look at when patients come into the dialysis unit, if they are more fluid overloaded, would they report worse sleep? And the metric that we used was hydration status, and this is based on previous literature. When the hydration status was less than 6.8%, that was considered normal hydration. 6.8 to 15% was mild overhydration, and greater than 15% was hyperhydration. So that was our predictor variable, looking at how fluid overloaded they were before dialysis. The outcome variable was looking at what they reported for sleep. So we used a standardized questionnaire to categorize their challenges with falling asleep, waking, and returning to sleep. And these were graded on 4 levels of how frequently this happened. The patient characteristics were slightly different in terms of age and male sex, and as well as BMI, but we adjusted for all of these factors in the final analysis. So these are some of our results, and this is the striking thing just right off the bat. This is just looking at patient characteristics. You can see this is the 50% line. So the dark and this gray are patients who have trouble falling asleep all or most of the time or some of the time. So you can just see right off the bat, almost 50% of the patients in this cohort said that they had pretty significant troubles falling asleep, waking up, and waking up too early and having trouble returning to sleep. So just right off the bat, you can see that these patients are not sleeping very well. And this was a plot looking at basically the association between relative hydration status. So these were the more volume overloaded patients on this side. These are the less volume overloaded patients, and how much sleep they actually reported they were getting. And you can see a linear relationship. As the patients came in with more volume, they were more likely to report fewer hours of sleep. And this was actually teasing that result a little bit, teasing that apart a little bit more. We were trying to see at what phase did they have trouble with sleep. Was it falling asleep, waking at night, or returning to sleep? So there's no real difference. So the circle is the mild overhydration group, and the square is the hyperhydration group. There's no real difference in falling asleep, no statistical difference. There was with waking. The patients who by BIS had greater volume overload had had a definite increase in challenges with waking in the middle of the night. And then there was kind of a trend to an association with difficulty returning to sleep with the more volume overloaded patients. So primarily it's really challenges waking at night, but you can tell this just adds more evidence to the fact that if patients are not truly at their dry weight, if they're volume overloaded, if they're hanging on to residual fluid even after the dialysis treatment, it will impact their quality of life. So in one of the final studies I'm going to discuss, just briefly, we wanted to look at markers of volume overload with physical function score. And the short form 36 is an instrument that uses 36 questionnaires to assess health-related quality of life. And the PF score is the physical function scale, which uses 10 items that are ordered to basically assess physical function. And these tools have all been validated on a 100-point scale. So basically I'm not going to go into the depth of this study because it had a lot to do with echocardiogram and kind of more subtle features. But what I did want to show you from this paper was that when you're volume overloaded, your ECF per volume per liter, your physical function score drops by about 2.6 on that scale. And what you get from chronic volume overload is LVH. And when you're per 5 millimeters of increased posterior wall thickness, you have a difference of about 7 in your physical function score. So to put that in perspective, your physical function score at a decade change, so going from 50 to 60 or 60 to 70, is supposed to change somewhere between 3 to 5 on the scale. So 2.6 with 1 liter of fluid excess kind of gives you an idea of how much residual fluid volume can impact the kind of physical function at baseline of a patient on dialysis. So with that, I will thank my mentors that have helped with some of this work and take any questions. Yes. I'm looking to do some more to carry this work out.
How they determine the fat-free body mass. So I guess some of those studies were done on patients like the one you showed, I guess, as typical patients in California. Now, how does that equation change when you're talking about our average Louisiana patient, where the fat-free mass maybe percentage of their body is still much lower?
Yeah.
So can you apply those equations in those patients to over here? In other words, has a validation study been done on an obese population?
That's an excellent question.
It's typically 36 or more in our dialysis patients.
That's a good question, and I looked at that specific question because we had outliers in our study with that exact problem, and it hasn't been looked at. And from what I can gauge, BIS, at least in our sample, did not perform well in those patients. They did have trouble with the extreme, the very obese patients.
So when these companies market these tools, that machine is marketed in Europe, I've done a couple of studies with collaborators in Hungary. So those equations remain the same. So you really cannot apply it to the different population unless it will be validated.
Right. So yeah, there's definitely a need. And when I did these studies, one of the challenges is to define volume overload. There are actually probably like 3 or 4 methods to define volume overload using BIS, and they haven't all been validated. So that is still an early kind of point of development in the research.
Some studies have looked at inferior vena cava or IVC collapse on ultrasound as a measure of volume. Has anyone correlated BIS with IVC collapse?
I don't think specifically because again, I mean IVC dilation is such a qualitative thing. It's like yes or no. So it'd be hard to know. I don't think there are any objective studies looking directly at BIS with this. But again, you wouldn't know, I mean, even if they're a little volume overloaded or significantly, it would be hard to tell, but it would be interesting to see what threshold you actually do get IVC dilation, but there aren't any studies that match it. Thank you.